Actually, there is no consensus about this location. So I will give you my point of view and we will discuss it thereafter. Postoperative location depends on the risk of the patient for postoperative complication. So we have to define who are the very high-risk patients. Obese patients are divided into 3 classes according to their BMI. And there is evidence that only class 3 obese patients, that means patients with a BMI greater than 40, and mainly patients with a BMI greater than 50, are at higher risk of postoperative complication. OSA represents also an important risk factor. OSA is classified in mild, moderate, and severe, depending on the AHI. AHI is the mean number of apnea and hypopnea per hour of sleep. It's now well established that only severe OSA patients and mainly untreated severe OSA patients are at risk of postoperative complication. Finally, and it's for me the most critical point, the probability of postoperative complication is influenced by the type of surgery and the type of anesthesia. I will not discuss how to manage anesthesia as my 2 colleagues just did it, but concerning surgery, the open surgery, the long-lasting procedures, the revision and emergency are at higher risk. So high-risk patients are class 3, untreated severe OSA and these types of surgery. For the obese patient, the main benefit of a monitoring is the prevention of a fatal complication following another complication which is not fatal. I will take the example of the cardiac arrest following an apnea. When the apnea occurs, the expired CO2 will drop immediately. The SpO2 will drop more or less rapidly depending on whether the patient is receiving or not oxygen. And finally, the heart rate will decrease lately. And if breathing doesn't resume, the situation may progress to the cardiac arrest. In an unmonitored bed, there is a high probability that the nurse will find a dead patient in the morning. The monitoring allows the detection of early warning signs and thus increase the safety of your patient. However, you cannot place all of your patients in the ICU. Firstly, there are not enough places, there is not enough money. Secondly, if you point out a very high-risk patient and you apply to them a personalized medicine, you reduce the probability of having such complications. In the same way, many authors consider that obese patients should benefit of an enhanced recovery program. And in that way, the ICU may not be the better place for the postoperative location. Finally, in 2020, there is still ICU department where during the night there is a lot of lines, sounds, alarm, noise. I know that in Montpellier you are particularly watchful about this concern, but it's not the rule in our ICU department. And all of these disturbing, stimulating factors decrease the proportion of REM sleep during the first night spent in the ICU. And this decrease is followed by a rebound some days later. And this rebound is of concern because during REM sleep, the duration of the apnea is much longer than during non-REM sleep. You see on the right the duration of the apnea during REM sleep and duration during non-REM sleep. And you see that in REM sleep, you have very, very long-lasting apnea of 60, 80 seconds and maybe more. And the longer the apnea is, the higher the risk for postoperative complication is. Otherwise, you have some tricks to improve the safety of your patient without using ICU. Firstly, you can use non-invasive ventilations like CPAP, BPAP, or PSV. If you are interested with these topics, you have this afternoon topics with Samir and Audrey who will address this point. If you don't use non-invasive ventilation, you can add oxygen to your patient during the night. And surgery permitting, 30 to 45 degrees head-up tilt may be beneficial for the patient. You see on the right of the figure that the semi-seated position decreases the probability of upper airway collapsibility in comparison with the supine position. Finally, I'm advocating for opioid-free anesthesia, but if opioids are needed in postoperative care, PCIA should be used. So, my algorithm, my conclusion, among obese patients, I only take into account class 3 obese patients. Among them, you have to answer the 3 following questions. Is BMI greater than 50? Has the patient an untreated severe OSA? And is surgery a major surgery? If you answer yes to at least one of these questions, patient should be placed in a monitored bed. If no, you should consider how your patient is in the recovery room, and mainly, has your patient a major respiratory events in the recovery room, such as a severe saturation. If yes, you should place your patient in a monitored bed. If no, you can place your patient in an unmonitored bed. But I will address you one last point to this last line. There is one thing what we don't have discussed until now, is that the obese patient obesity is related to many other comorbidities. And for these patients, this last line of patient, you have to choose individually if patient should be placed in a monitored bed or no. And this choice will be guided by the comorbidities of the patient and by the type of surgery. Thank you for your attention.
Thank you for this very clear talk with home-taking messages. We have a question from Aurelia for you. They are astonished, very surprised, about the 3 grams of magnesium in your protocol. 3 grams, it's a lot. How do you administrate it? Infusion, slow injection? How many times before incision? These are the questions.
Okay, thank you for this question. It's supported by one recent study that they use 3 grams of magnesium, and we use 15 minutes before incision of the surgery, and with slow intravenous infusion, slow about 15 minutes until the induction. 15 minutes before the incision.
15 minutes before the incision,
and this is the time that for infusion of magnesium. So
okay, thank you. And I have one question for you, Eric. How do you individualize the risk of complication of the obese patient? You say at the beginning, individualized assessment.
I think that personalized medicine is one of the major points for anesthesia in the next years. We have personalized medicine is tailoring medicine to each patient and not the opposite. Until now, we applied the same medicine to all of our patients, but personalized medicine is tailoring medicine to each patient. Now we have a lot of predictive scores for a lot of things, for cardiac events, respiratory events, for pain, for postoperative cognitive disorder, for a lot of things. And thus we can take all of our patients and put them in different subgroups. And these subgroups can have a specific treatment. I will take one example of the team of Matthias Eickermann from Germany, who is currently working in Boston, and they include more than 100,000 patients in their study. And they categorize them in at risk or not for OSA, or rising on score. And for a patient at risk, they applied specific treatment. No premedication, very low dose of opioids, etc. And they have demonstrated that this subgroup of high-risk patients has finally less complication than the general population. So you take very high-risk patients and you apply only to them specific treatment that take time, etc. And thus you reduce the probability of having a complication.
Okay, thank you very much for this very clear answer.